Welcome to another deep dive. You know, as neurologists and physicians, there are conditions that we really need to keep on our radar. And today we're going deep on one that often flies under the radar, Eagle syndrome.
Yeah, absolutely. And for us, especially the vascular complications of Eagle syndrome, we have to be so careful with this. Specifically, it's linked to internal carotid artery dissection. Misdiagnosis is a real concern here, right? And it can have devastating consequences for our patients.
You're right, it really drives home the importance of staying sharp and informed. We've got a great guide for today's deep dives, a recent case series in interdisciplinary neurosurgery, and it features two really interesting patient cases that highlight just how varied Eagle syndrome can be, especially when it comes to that vascular variant.
I think these cases are so valuable because they're a real-world look at why this is such a critical condition for us to understand. It can present so differently from patient to patient.
So let's start at the beginning. What is Eagle syndrome?
Well, we have to go back to 1937 when Dr. Watt Weems Eagle first described it. And at its core, you're looking at an elongated styloid process or a calcified stylohyoid ligament, so that bony projection just below the ear.
Now, the styloid process has its normal function, of course. What leads to this elongation or calcification? What's the mechanism there?
That's a question that researchers are still grappling with. There are some theories, of course. Some point to developmental issues, maybe something that happens during fetal development. Others suggest it could be related to changes in how bone metabolism works over time.
So a bit of a mystery still. You mentioned this affects about 4% of the population, but not everyone with an elongated styloid process has symptoms, right?
You got it. A very small percentage, something like 0.16%, actually go on to develop full-blown Eagle syndrome. And within that, we've got two main types to be aware of: the classic presentation and the vascular variant, as we've been talking about.
Okay, let's unpack those a little. What does the classic presentation look like?
In a classic presentation, pain is the dominant feature. Patients might have pain when they swallow, headaches, neck pain that radiates up to the ear. It can be quite debilitating, really significant pain.
Sounds like a real challenge diagnostically, given all the other conditions that could present with similar symptoms.
Absolutely. And to make things even trickier, the pain is often worse with certain movements. Things like yawning, turning the head, or even chewing. And that's because that elongated styloid process is pressing on those cranial nerves. We're talking the trigeminal, the facial, the glossopharyngeal, and the vagus.
That makes sense considering the variety of symptoms it can cause. But then we've got that vascular variant, which I think is especially concerning for us.
Absolutely. And that's where things can get really serious, because now we're talking about the impact on blood vessels, specifically the carotid arteries and even the jugular veins sometimes.
So this is where the risk of stroke comes into play.
Precisely. Patients with the vascular variant might experience headaches, those transient ischemic attacks, or even full-blown strokes. It's a whole different ballgame compared to that classic presentation.
So how does an elongated styloid process actually lead to a stroke? Can you walk us through that?
Sure. So picture the anatomy. The internal carotid artery, the ICA, runs right by the styloid process. If that process is elongated, it can actually press on or irritate the ICA, and that can cause a tear in the artery wall.
An ICA dissection, right?
That's right. And an ICA dissection is serious business. It can cause a clot to form, and that clot can travel to the brain, block blood flow, and boom, stroke.
This is where those case studies from the interdisciplinary neurosurgery article really hit home. They paint such a clear picture of these concepts.
I agree. They're a great way to ground our understanding of the challenges and decisions we face in diagnosing and managing Eagle syndrome.
Let's start with case one. This is the patient who presented with that vascular variant, right?
Exactly. A 44-year-old male had a history of uncontrolled hypertension. He presented with sudden left-sided weakness and this awful headache that hit him while he was driving.
That sounds like a classic stroke presentation.
It really does. But here's the thing. He'd been experiencing right-sided neck and facial pain for 9 months before this episode.
That's a really important detail. Almost a red flag that there was something else going on, right?
Right. And imaging really confirmed that. It showed he had a right middle cerebral artery infarct, an MCA infarct, and that right ICA dissection we were concerned about.
And it was caused by, you guessed it, the elongated styloid process.
Right. Again, the imaging showed prominent elongated styloid processes, especially on the left side. So really fit the picture of Eagle syndrome.
So they gave him TPA, the clot-busting medication. What happened then?
Well, initially he improved after the TPA, but about 48 hours later, his symptoms got worse. It seemed like he had another clot form, and that caused a larger stroke.
Oh, wow. Talk about a complicated situation. Did they think about doing any surgical intervention at that point?
They did consider an endovascular procedure, but they decided against it because of the dissection and the risk of complications. It was just too risky at that point.
That makes sense given how delicate that situation was. So what did they end up doing for this patient?
They put him on aspirin and atorvastatin to help prevent future strokes. And critically, they referred him to a head and neck surgeon to consider a styloidectomy.
So the goal there being to remove that elongated styloid process and hopefully prevent any more dissections down the line.
Exactly. Now, let's move on to case 2. This one was a really good example of that classic presentation of Eagle syndrome. It involved a 41-year-old male, and his main issue was this refractory occipital headache, so a headache at the back of his head that just wasn't responding to the usual treatments. He'd also been dealing with neck pain for about 6 months.
So mostly pain symptoms at this point. Was there anything else that pointed toward Eagle syndrome in this case?
Well, he did have a history of dyslipidemia and episodes of palpitations. And when they examined him, he reported some other things too, like the feeling that his ear was blocked, numbness in his limbs, and even some pre-syncope. So, like, he was about to faint.
Interesting. So a pretty different clinical picture compared to that first case, but still some red flags there.
Definitely. And when they did an MRI with venogram, it showed he had elongated styloid processes bilaterally. And get this, they were actually compressing his internal jugular veins.
Wow, fascinating. So even though he didn't have a stroke, those elongated styloid processes were still causing significant issues.
Exactly. It really shows the variety of ways Eagle syndrome can present. It's not always about stroke, but it can have a big impact on someone's health and quality of life.
So in this case, did they also refer him to a surgeon?
Yep. Initially, they managed his pain with NSAIDs, but then they referred him to the maxillofacial team to discuss a styloidectomy. The idea was to get rid of that chronic pain and potentially prevent more serious issues down the road, like that ICA dissection.
These cases really highlight something important. It's not just about whether the styloid process is elongated. The length and angulation really matter too, right?
Absolutely. You're right on the money there. Let's dig into that a bit more. So we're talking about a normal styloid process that's about 25 to 30 millimeters long, right? And research suggests that every extra millimeter, it actually increases the risk of an ICA dissection.
Wow, so it's like a ticking time bomb almost. The longer it gets, the higher the chances of a dissection.
Yeah, that's a good way to think about it. And it's not just the length either. The angle, the angulation of that styloid process matters too. Some angles are just more likely to put pressure on that ICA, making a tear more probable.
This really underscores how important imaging is when we suspect Eagle syndrome, right? You need to get a good look at what's going on in there.
Oh, absolutely. A plain X-ray often won't cut it. It's just not detailed enough to catch those subtle variations. And orthopantomogram and OPG can be useful. It gives us that panoramic view of the jaw and skull. But honestly, for the most accurate assessment, you really want that 3D CT scan. That's the gold standard.
And if we're thinking there might be vascular involvement, like in that first case we talked about, an angiogram would be needed to actually see the blood flow, right?
Exactly. With an angiogram, we can visualize the blood flow in those carotid arteries, see if there's any dissection, any stenosis. It gives us that level of detail we need to make informed treatment decisions.
It's amazing, isn't it? Something as seemingly small as an elongated bone can have such massive repercussions, especially when you're talking about the vascular system. You know, thinking about it from a clinical perspective, what are some of the signs of Eagle syndrome that we might miss? What should we be extra vigilant about?
That's a great question. I think one of the biggest challenges with Eagle syndrome is that the symptoms can mimic so many other conditions. Patients come in with headaches, neck pain, ear pain, and it's easy to think of the more common diagnoses first, right?
So how do we as neurologists, as physicians, get better at catching it early on? How do we make sure we're making that accurate diagnosis?
Awareness. Awareness. We need to keep Eagle syndrome in our minds, especially when we have a patient with unexplained head and neck pain. Or if we see an ICA dissection that doesn't seem to have a clear cause, like trauma, it has to be on our radar.
So being thorough with the history, the physical exam, really listening to what our patients are telling us about their symptoms, not just brushing it off as another headache or neck pain.
Exactly. Ask the right questions. What kind of pain is it? What makes it worse? Has there been any trauma to the head or neck? And then a careful physical exam is crucial, paying close attention to any tenderness in the head and neck area.
And of course, as we've already touched on, those imaging studies are critical for confirming the diagnosis.
Absolutely. If the clinical picture even hints at Eagle syndrome, those imaging studies need to happen, no question. It's always better to be safe than sorry.
Let's switch gears a bit and talk about treatment options. I imagine for that classic Eagle syndrome, conservative management is usually the first step, right?
Yeah, you're right. We'll often start with pain medications, things like NSAIDs. Sometimes we'll even consider nerve blocks to help manage the pain. Lifestyle modifications can be helpful too, like advising patients to avoid certain movements that trigger their symptoms.
But with that vascular variant, especially when you have an ICA dissection, things get a bit more intense.
Right. And a lot of times that means surgery, specifically a styloidectomy.
And that's removing that elongated part of the styloid process, correct?
You got it. The goal is to take the pressure off, decompress those nerves and blood vessels that are being squeezed. Now, there are two main ways to do this. Intraoral, where they go through the mouth to access the styloid process, and extraoral, where they make an incision in the neck.
Now, I'm wondering, why didn't that first case, the one with the ICA dissection, go straight to surgery? It makes you think about how we make those decisions when it comes to Eagle syndrome.
It's a really important point. When you have a stroke happening, the priority is stabilizing the patient and dealing with that immediate threat. A styloidectomy, while it's often recommended to prevent future dissections, might not be the best option right then and there.
Makes sense. In that moment, with an active dissection, surgery could potentially make things worse. So it's a judgment call, weighing the risks and benefits. The decision to do a styloidectomy often comes later, as a preventative measure once the patient is stable.
Precisely. It's not a one-size-fits-all approach. You have to consider each patient individually, their specific situation. It's a team effort, too. The neurology team, the vascular surgeons, the head and neck surgeons all need to be involved in that discussion.
So going back to those surgical approaches, I understand the intraoral approach is often the preferred method. Why is that?
It's generally considered less invasive, which means quicker recovery for the patient, lower risk of complications. But the best approach really depends. The patient's anatomy, the surgeon's experience and preference, all these factors play a role.
This brings up another question that I think a lot of us grapple with. When is a styloidectomy actually necessary? It seems like there's still some debate in the medical community about when surgery is the right call versus when a more conservative approach is enough.
There is, for sure. And unfortunately, we don't have those clear-cut guidelines to help us make that decision every time. Some experts say any patient with symptomatic Eagle syndrome should have surgery. It's the best way to relieve symptoms and prevent future problems, they argue. Others prefer to wait and see, reserve surgery for those cases where conservative management hasn't worked or there are signs of vascular issues.
So it seems like we need more research, more data to help us develop those clear guidelines and better understand the long-term outcomes of different treatment approaches.
Absolutely. We need more information to make the best decisions for our patients to ensure they're getting the best possible care.
This deep dive has been incredibly informative. It really highlights how complex Eagle syndrome can be. As we wrap up this part of our discussion, what are the key takeaways you want our listeners to remember and apply in their practice?
I think the biggest thing to remember is that Eagle syndrome, though rare, has to be on our radar. Those symptoms can be tricky, easily mistaken for other conditions, which can lead to misdiagnoses and potentially serious consequences.
Especially with those vascular complications we talked about.
Exactly. Early recognition is everything. We have to be alert to the possibility of Eagle syndrome, especially in those cases of unexplained head and neck pain or those atraumatic ICA dissections. It can make a world of difference for our patients.
So a high index of suspicion, a thorough clinical assessment, and those targeted imaging studies are crucial tools in our arsenal.
Couldn't say it better myself. It's about putting those pieces together, being proactive in our approach.
Looking ahead, what are some of the big unanswered questions in the field of Eagle syndrome? What do we need to focus on in terms of research and understanding this condition better?
There's still so much we don't know. Why do some people develop these elongated styloid processes in the first place? And why do only some of them actually have symptoms? Those are fundamental questions that we need to answer.
And from a clinical perspective, what are the areas where we need more research to guide our practice?
We need better diagnostic criteria. How do we accurately identify those patients who are most likely to benefit from surgery? How do we know who will do well with conservative management and who will eventually need surgery?
Those are the questions that really impact how we care for our patients.
Exactly. We also need to know more about the long-term outcomes of different treatments. How effective is a styloidectomy at relieving symptoms and preventing future dissections in the long run? How does that compare to conservative management? Those are really the key questions, right? The ones that impact how we manage these patients day to day. So much more research is needed there.
Absolutely. We've learned so much already today. It just underscores how much more there is to uncover. Thinking about styloidectomy, are there any specific factors that make you lean toward one surgical approach over the other, the intraoral versus the extraoral? Is it pretty straightforward, or are there nuances we need to be aware of?
It's definitely not always a black and white decision. Surgeons consider a lot of factors. We talked about how the intraoral approach is generally preferred, less invasive, quicker recovery, all that. But sometimes the extraoral approach is the better choice.
In what situations would you opt for the extraoral?
Well, if that styloid process is super long, or if it's got a really complex angle, the extraoral approach can give the surgeon better access, better visibility. It also lets them control any bleeding better and gives them more room to address any other anatomical variations that might pop up.
So each case, each patient, needs to be evaluated individually. The surgeon has to use their experience and judgment to make that call.
Exactly. And that's why communication is so important. The neurology team, the vascular team, the surgical team, everyone needs to be on the same page, working together to manage these complex cases.
I think our listeners are probably thinking about their own patients right now. What are some of the red flags that should make us think about Eagle syndrome, even if it's not our first thought? What should make us pause and consider it?
I think the most important thing is persistent head and neck pain that just doesn't get better with the usual treatments, or pain that presents in a way that's just not typical. So if a patient comes to you with a headache, neck pain, facial pain, and it seems a little unusual, or if certain movements trigger the pain, like turning their head or swallowing, Eagle syndrome should be on your differential.
What about those cases of ICA dissection where there's no obvious trauma? What should we be looking out for?
Anytime you have an ICA dissection without a clear history of trauma, you got to think about what else could be going on. And Eagle syndrome needs to be on that list. It's also worth remembering that not every patient with Eagle syndrome will have a history of pain. Some might come in with those vascular symptoms first, so it's important to keep an open mind. Don't get tunnel vision on one diagnosis.
So basically, we need a high index of suspicion. We can't just dismiss symptoms that don't fit the textbook definition. We have to be actively looking for these less common conditions.
Couldn't agree more. Step back, look at the whole picture, consider all the possibilities, and of course, don't forget about imaging. That's crucial for ruling things in or out.
Well, this deep dive into Eagle syndrome has been eye-opening. We've covered so much ground: the anatomy, how it happens, the challenges in diagnosing it, and the latest treatment options. But as we've said, there's still a lot we don't know, and more research is needed to move the needle forward and improve care for our patients.
I completely agree. This has been a great discussion, and it highlights that even small anatomical differences can have a huge impact on our patients. It's our job to stay informed, keep learning, and always be questioning, always be curious.
So as we wrap up, what's the one thing you want our listeners to take away from this conversation? What should they be thinking about?
I'd encourage everyone to think about their own experiences. Have you had cases that, looking back, could have been Eagle syndrome? Maybe a patient with persistent head and neck pain that didn't quite fit the pattern, or an unexplained ICA dissection? Take a second look at those cases with this new knowledge in mind.
It's always worth revisiting those cases, especially with a fresh perspective.
Absolutely. And thinking forward, how can we use what we've learned today to refine our diagnostic process? Should we be more thorough in our head and neck exams? Should we be ordering more imaging studies in certain situations? These are the questions we should all be asking ourselves.
It's all about pushing ourselves to get better, to provide the best possible care to our patients.
Exactly. Stay curious, keep those minds sharp, and let's keep pushing the boundaries of what we know in medicine.
Thanks to everyone for joining us for this deep dive into Eagle syndrome. We hope it's been helpful and that it'll spark more discussion and learning in your practice.
It's been a pleasure. Until next time.